Okay. Right, hello everyone, and thank you for joining our webinar, which is called A Philosopher's Approach to Equality today. I'm Polly Kerr, and I'm the Patient and Public Involvement Manager for the Oxford Biomedical Research Centre. And together with my colleagues, Claire Murray, who's the PPI Manager from the Oxford Health BRC, Biomedical Research Centre, and Claire Schwartz, PPI and Programme Manager from the Applied Research Collaboration for Oxford and the Thames Valley, and our public contributors, Hubert Allen, Kath Greehey, and Julia Haber-Hunt. We are hosting these webinars for patients and members of the public who are involved in research or who are interested in getting involved. In a minute, I'll introduce our speaker, but just to confirm, as I said already, we are recording today's session so that we can make it available in our website, on our websites afterwards. So please keep your cameras off and your microphones on mute. There'll be about 15 to 20 minutes for questions after the talk. So please submit these using the chat function. These are just going to come through to the organisers initially, so they won't immediately be visible to everyone, but they'll then be published, and we'll then put them to Sapfo to answer. And just a reminder that these webinars are aimed at increasing patients' and the public's knowledge and understanding of research, so we'll prioritise the questions to reflect that. Finally, from me, we'd really love to get your thoughts on this webinar, so we'll be sending you a very short questionnaire via Eventbrite afterwards. Please keep an eye out for that, and we'd really be grateful if you could fill it in, because we use all the feedback for planning our future webinars. And now I'm really pleased to hand over to our speaker for today, Sapfo Lignou, a researcher with the Neuroscience, Ethics and Society team at the University of Oxford's Department of Psychiatry.
Hi everyone, I'm a researcher in the Department of Psychiatry and a member of a neuropsych team. My work focuses on the ethical justifications for patient and public involvement in research, and I'm also a researcher at the Wellcome Center for Ethics and Humanities at the University of Oxford. So basically, when I want to present part of my work today, we already know there is a lot of important work taking place recently on how to improve the inclusion of underrepresented and often neglected from research groups in patient and public involvement. The aim of my own research is not to provide to researchers practical guidance on how they can improve their PPI approaches, but mainly to identify ethical challenges in involving underrepresented and marginalized groups in patient and public involvement. And taking this into account, my presentation today has three main objectives. The first one is to present ethical challenges in involving underrepresented and marginalized groups in patient and public involvement that highlight aspects of the debate over patient and public involvement that remain unanswered. Then I will explain why these ethical challenges are important and what are the practical implications for the work of health researchers. And then finally, I will suggest an ethical framework, a moral approach of how these ethical challenges can be addressed and how difficulties in how we understand equality of opportunity, patient and public involvement can be understood and implemented in practice in more consistent way. Before I start presenting these ethical challenges, I thought it would be useful to give a few definitions. First of all, by patient and public involvement, I refer to actively working in partnership with patients and members of the public to plan, manage, design, and carry out research. Also, I refer to seldom health groups, underrepresented groups in research, or marginalized communities, in order to refer to people who find it more difficult to be involved in research. My aim is not to provide a comprehensive list of who find it difficult to have their voices heard in research, as this will vary across different contexts and research, and also it will depend on people's views of how they find it difficult to have access in patient public involvement. Now, as we know, patient public involvement is becoming an established practice in health and social care research. But the problem is that patient and public involvement is often perceived as being exclusive and not representing the diversity of population as a whole. As it's stated in Going the Extra Mile, opportunities to involvement are not always accessible to wider population. And also, as we can see in one of the NIHR's website, those getting involved are those people who are usually easiest to involve. People who are used to being involved with an existing connection with their organization, who are able to volunteer the time and energy, and who understand how organizations such as research institutes work. It's also stated in the info that those excluded from research are usually those who are also excluded from social life. People with complex and multiple impairments, older people, or those holding undesirable views, those from marginalized communities such as refugees. To address this problem, and as part of a broader initiative to foster an inclusive research environment, research organizations and funders such as NIHR have clearly stated their commitment to provide equal opportunities to everyone to be involved in research. Involving people from diverse backgrounds requires real commitment to equal opportunities and implementation of effective practical measures. It's also stated that further work is needed on equalities in involvement and how existing structures aim at facilitating equal opportunities might in fact continue the exclusion of groups who are already alienated by organization structures and procedures. Also involve advises researchers to pursue the active involvement of service users and carers, including where appropriate those from hard to reach groups such as homeless. Now, a commitment to strive for equality and address any barriers to involvement seems a non disputable moral good. However, this commitment to be translated in practice poses challenges. And this is because it's often not clear when equal and unequal access or absence of patient and public involvement is morally problematic. We can broadly identify two different approaches that give us different understandings on when and why unequal access to patient public involvement can be addressed. One of them is the outcomes-based approach, which basically focuses on the outcomes of research. According to this approach, involvement helps to ensure that the entire research process is focused on what is important to people and is therefore more likely to produce results that can be used to improve health and social care services. According to this approach, unequal access is unjust when there is a risk the research will not benefit from the insights and experiences of those affected and will not be responsive to their needs. We can understand and relate to studies that have specific to particular marginalized groups or general studies as COVID research where the insights of those not usually included in research will be important for the relevance of research, or other stages of research, such as stages where marginalized and those not usually involved in research will help with the recruitment of underrepresented research participants. On the other hand, there is a different account that gives us different justifications when unequal access to patient public involvement can be considered unjust. According to Rice, based on emancipatory approach, involvement is valuable because it can empower people and provide a route to influence change and improvement in issues that concern them the most. Unequal access, according to this approach, is always unjust. The absence of particular groups devalues the experimental knowledge of excluded groups, and it's often described as a form of epistemic violence or epistemic injustice. According to this account, equal opportunities are a morally imperative irrespectively of the aims or types of research. Now, taking into account these different approaches of when unequal access is unfair for those usually not included in patient and public involvement, several questions are raised. Is unequal access to patient and public involvement problematic simply as an inequality because those usually not involved do not have the means to be involved? Or is it unjust because it can prevent a study to be relevant for some groups of patients? Do health researchers have a duty to address social inequalities or strive for other aims and values, such as promote social justice by their PPI approaches? Or can we even argue that health researchers do not have a duty to those kind of aims, but only to comply to the professional guidelines and requirements, such as to avoid exploitation or discrimination when it comes to PPI contributors? And the way these what are the right answers to this question will not be the same and will depend on different perspectives that PPI contributors and researchers hold. And because of these differences in the way we understand how to address and understand these questions, there are several complications when it comes to the work of health researchers. One of them is when they have to decide what is the right selection method when they decide or assess their PPI approaches. Should they aim for random selection that will give everyone some chance to be the same chance to be involved? Or should they aim for a positive action plan? This plan will increase the opportunities to those excluded research, and in this way can be claimed to reduce power imbalances between researchers and seldom heard patient groups. Also, taking these problems into account, how priorities in addressing inequalities in access to patient public involvement should be decided. Some barriers to involvement may be more or less difficult to overcome. For instance, we can think that different resources or efforts might be needed in order to enable access to those that might need assistance to participate due to physical impairments, while different also resources might be needed in the case that we want to enable access to those facing more than one set of barriers. For instance, the case of mental health service users in the prison system. And of course, when we talk about resources, we also have to think about costs, have to think about money, time, and training. And all these then might be justified to raise the barriers in order everyone to be able to be involved in patient and public involvement in research. So another important ethical question that needs to be considered is that consideration of social justice or the aims to promote other values may slow down the conduct of research. In this case, how can we balance the costs and benefits of providing all resources needed to those usually excluded for patient public involvement and give researchers other moral responsibilities and professional responsibilities, such as to meet project deadlines? There are two main questions in this case that need to be addressed. The first one is how to address these ethical and practical challenges when researchers aim to improve the PPI strategies and include those usually not included in patient and public involvement. And the second one is how equality of opportunities should be understood and implemented in practice in a consistent way to avoid confusion and waste resources. In order to address these challenges and see how they can better be understood, I suggest a framework on duties of health researchers that allows a broader perspective of this issue. I will mainly focus on this question: what do health researchers owe to those usually excluded for patient and public involvement? And to answer this question, I will identify different kinds of moral duties as key considerations health researchers across different types of studies. In moral philosophy, we can broadly make a main distinction when it comes to duties. We have perfect duties and imperfect moral duties. Perfect duties are those that usually have perfect duties are those who have corresponding rights and therefore can be claimed by others. They're not negotiable and therefore they're not a matter of personal preference. An example of perfect duty is our duty not to harm other people. Imperfect duties, on the other hand, are those that don't have corresponding rights. And one example of these duties is our duty to help others. We are not required to do everything that we can in order to help others, and we are free to choose how often we can fulfill this duty. Now, taking these broader categories into account, we can say that health researchers, when they come to the involvement of those usually excluded from patient public involvement, have perfect and imperfect moral duties. A form of perfect moral duties that is not up to researchers to decide whether they should be fulfilled or not is their duty not to exclude anyone in their PPI strategies based on the morally arbitrary characteristics such as gender, ethnicity, social status, religion, political beliefs, and others. This means that all researchers, with no exceptions, should ensure that their PPI selection processes are impartial and do not systematically favor some groups over others. Therefore, members of marginalized, neglected communities have a corresponding right not to be excluded from PPI due to discrimination. There is another type of perfect moral duties that researchers have to those not usually included in PPI approaches. This other form of perfect duties, the researchers also have a moral obligation not to neglect and always fulfill, are called spatial perfect moral duties, and were based on the special relationships that some researchers have with specified groups and communities of people who are usually not included in research. Researchers have a duty to involve PPI contributors from the communities that are being researched in order to produce a more appropriate research design and more relevant research outcomes. These duties are compatible with care researchers' professional obligations, and this is one of the main reasons that these are not negotiable. And one of them can be understood as their obligation to deliver a relevant and relevant research according to the needs of these populations and communities, and also results that will be applicable. And also, in order to fulfill these duties, there are certain actions that researchers need to take. They should have a moral obligation to adjust their PPI approaches, give priority to these groups for which research is designed, and to consume all the necessary resources in order the voice of who there need to be heard to be included. But researchers do not only have moral duties to involve those usually excluded from public and patient involvement for reasons that are specific to their own research aims. There are also duties which can be considered as imperfect moral duties that can be compatible with their aim to involve marginalized and those not usually included in patient public involvement. Some cases, patient public involvement can be compatible with the aim to alleviate social disparities, empower neglected from research communities, address relations of alienation between neglected from research communities and researchers. And these can be considered as the duties that researchers have towards the society in order to fulfill their moral duty to engage in activities that will benefit society. And researchers have these obligations to society because they have been benefited directly or indirectly from government support of their education and research. Now we can see that these duties, the imperfect moral duties that researchers have to those usually not involved in research, have a great moral importance. They can have a significant impact if they're widely practiced and benefit these communities and society in general. When compared to perfect moral duties, they have a lower priority. This means that overcoming every possible barrier in order to include people usually excluded for patient public involvement is not an absolute requirement and may be overridden by other professional responsibilities of researchers. For instance, in order to complete their research projects. They can also be overridden because of researchers' other responsibilities, such as the duties they have to PPI contributors to ensure that their needs are met by building their skills, offering the practical help that they need in order their involvement to be meaningful. And this is the most important part that I want to highlight in this presentation, that accessibility is not only about providing people with equal opportunities to be involved in research, but also to participate fully in whatever is being offered. We know that people who are usually excluded from PPI approaches face different barriers. People might be lacking the opportunities to patient and public involvement due to their personal abilities, for instance, disabilities and illness, or because they're not enough available resources, they might lack training or even cash conversation or other reasons, for instance, cultural issues on the attitude about research. In several cases, researchers are able to raise these barriers, but there also might be cases that researchers would not have the capacity and they might be considered impaired in some way. For instance, when they don't have enough resources in order to compensate or pay for the expenses of PPI contributors, or whether when they don't have the particular training in order to understand cultural barriers and address them. In those cases, we can claim that researchers are exempted from this relevant obligation to provide equal opportunities to those usually not involved in research. To improve then the inclusion of those underrepresented communities in patient public involvement, two conditions are necessary. The first one is that the differences between people should be accepted, and the second one is that all service users, carers, patients should be offered genuine opportunities to inclusion. Therefore, while selection, recruitment, and importing processes could be changed to address problems regarding bias and discrimination in patient public involvement, a combination of different strategies is important to overcome unequal access and barriers to meaningful contribution. This is where I think that funders and research institutions have a crucial role. They can help researchers to improve their skills and also to have more resources in order those usually not involved in patient public involvement to be able to be involved and meaningful contribute. This can be done by ensuring that adequate funds are available to research teams to support successful recruitment to underserved groups, such as transportation or provision of translators. Also, they can support adaptable and flexible research that values the experience of various communities and groups. And one thing that that is raised often in the literature, empirical research, is that researchers need to invest in long-term relationships and to engage with broader communities prior to this involvement. And also, in order to achieve that, also support of research that aims to identify these multiple constraints for more inclusion involvement is necessary. As a conclusion, we can say that the main thing when it comes to consideration on how those usually neglected for patient and public involvement can be meaningful, be included in research, is that we should think about the possibilities of opening up spaces for a more inclusive involvement and what challenges might arise for researchers. And as I have presented so far, there is a wide range of considerations that can inhibit access to patient and public involvement. And this may include cultural and institutional practices, psychological barriers, financial constraints, and others. And given not all these constraints are the responsibility of a researcher or can be addressed by the researcher, more collective action is necessary. Research institutions and founders should take more initiatives to foster a more transparent and accountable and inclusive research environment. Thank you.